First topic is pediatric abuse and child abuse. It is one of the areas that are covered quite heavily within the examination, and certainly on the in-training examination, and also on the boards. So let's start with the first question. What are the two most common lesions seen in abused children? So to get this answer right, or to get this question right, you'll need to know some things about child abuse. One of the things that you'll need to know are those signs to look for, including multiple fractures in various stages of healing, corner fractures, which are fractures that result from a twisting mechanism to a limb. And you can see a nice illustration of that on this x-ray with both the black and the white arrow illustrating the healing corner fracture, which is really a fracture at the metaphyseal-physeal junction. Multiple bruises and skin lesions are very common in children who suffer from child abuse. In fact, they are among the most common things. A history of an unwitnessed injury, as well as long bone fractures in non-walkers or children under 18 months of age. The most important thing from an orthopedic standpoint is to be able to recognize those injury patterns, and also to order the skeletal survey and get a social worker or a social service unit involved. At most medical centers, this involves the pediatric surgery unit. So on this x-ray, you can see that this is a distal humeral physeal separation. The way we can tell that is the disconnect between the distal humeral metaphysis and the proximal radius and ulna. The proximal radius and ulna appear to be in an appropriate relationship, and the proximal radius is still pointing to the capitellum, which you can see, just barely see behind the distal humeral metaphysis. And the radius and ulna are together like they should be, but they are dissociated from the distal humeral physis, or distal humeral metaphysis. So in abused children, the most common lesions seen are skin lesions and fractures, and that's response number 2, and most of you got that right. So good job. The next question, a 2-year-old male is brought to the emergency room complaining of pain in the left elbow. Radiographs are shown in figures A and B. This injury pattern should raise concern for which of the following? And so, similar to the last question, you can see on this x-ray, the proximal radius and the proximal ulna are both in appropriate alignment. And the proximal radius is pointing toward the capitellum, as it should in all views of the elbow. And you can see on the lateral x-ray as well that the proximal radius is pointing toward the capitellum and is in an appropriate relationship with the proximal ulna, but both of them appear to be dislocated from the distal humeral metaphysis, and so this is a distal humeral physeal separation. Once again, it's important to recognize the injuries that are associated with child abuse, including the ones that we talked about. You also have to be aware of humeral physeal separation as well as posterior rib fractures, in addition to the ones that we talked about the last topic. So once again, a 2-year-old is brought to the emergency room with pain in the elbow. Radiographs show a distal humeral physeal separation, and this should raise concerns for child abuse, which is number 5. Once again, next is osteomyelitis, which you can see is another topic which is heavily covered in the in-training examination as well as on the boards. The question is defined as which of the following? So we'll spend a little time going over some information about infection, because this is, like I said, a topic where it's heavily tested. So osteomyelitis is a common cause of limb pain, and often there's a remote history of trauma associated with this, which makes sense, because trauma frequently will create a hematoma, which is then seeded by the transient bacteremia that we all have in everyday activities. So hematogenous infection, or hematogenous seeding, is the method by which this occurs. And this occurs in children more than adults because of their anatomy that consists of these end arterial loops in the metaphysis just proximal to the physis. And so in these regions they get metaphyseal sludging. Children have an incompetent immune system, and so they have a deficient reticuloendothelial system, so their ability to fight infection in this region is also diminished. because of the endovascular loops, there is increased vascular permeability. So all these things are a setup for infection. And typically, this starts in the metaphysis of the long bones. The organisms are a little bit dependent on the environment or and the age of the patient. So Staph aureus continues to be the most common organism that we see causing infection. It is becoming more frequent that this is a community-acquired methicillin-resistant Staph aureus in some locations. Kingella kingae is another common pathogen that we see in cases where their culture doesn't immediately show anything. So you have to be sure that in those cases that the laboratory continues to hold that culture and also inoculates it into a CO2-rich medium because this can be a fastidious and slow-growing organism. In neonates, group B strep and gram-negative organisms are a frequent cause of infection, and they ask this frequently on the test as well. In sickle cell disease, salmonella is the organism that is associated with it, although Staph aureus is still the most common organism for osteomyelitis in these people. Haemophilus influenza is now an uncommon cause of infection. It used to be a very common cause in the younger child, but due to the vaccine, it has essentially been eradicated as a pathogen in osteomyelitis. It does appear in those populations, however, that have not immunized their children. Terminology is important to know as well. Involucrum is a term that's used to describe new bone that's formed in an effort by the body to sequester the infection or to wall it off. The sequestrum is the nidus of residual necrotic infected bone, which is being walled off. Operative treatment of chronic osteomyelitis requires excision of the sequestrum. So once again, returning to the question, you can see that the correct answer is 3. That sequestrum is the necrotic bone, which is a nidus for infection in chronic osteomyelitis, and most of you got that right as well. Moving on, a 7-year-old boy complains of worsening left knee pain over the last 2 weeks. He has been unable to bear weight through the left lower extremity for the past 24 hours. The knee and lower leg are warm and tender to palpation. Current temperature is 100.9 degrees Fahrenheit. CRP is 11, which is elevated. A radiograph is provided in figure A. A joint aspiration yields 2 cc's of synovial fluid, demonstrating a cell count of 2,500. That's pretty unimpressive. And no organisms on gram stain. Which of the following is the most appropriate next step in management? So the radiograph they provide for you there shows an AP view of bilateral knees with normal physes. Clearly this is a skeletally immature individual. And the patella also look normal, and the x-rays seem normal on both limbs. So osteomyelitis is a problem that we see that presents clinically with warm, tender, swollen limbs, or a limb if it's one side of infection. There may be a history of antecedent trauma. Typically they present with a limp or the unwillingness or inability to walk. They often have a fever. The laboratory markers that are indicative of this process include an elevated white count, an elevated sedimentation rate, and an elevated C-reactive protein. And so these are important things to be aware of and to order clinically. Radiographs are often not very helpful in the early period, even up to 2 weeks after injury before they start to show some signs. MRI can be a very helpful imaging modality to help guide aspiration, and also in those scenarios where there's not an obvious area that seems to be causing the discomfort or pain. So it's important to know that the temporal relationship between CRP and sed rate. So sedimentation rate is typically something that rises a little bit more slowly and remains elevated for much longer, whereas C-reactive protein is elevated very early in the course of infection and then dramatically declines after treatment is initiated. So the time course for elevation and then a decline of CRP is a much better marker for early response to infection, whereas SED-rate is something that's used as a tracking lab for long-term antibiotic therapy. So once again, a 7-year-old boy with knee pain over a couple of weeks with unwillingness to bear weight over the last 24 hours, so worsening knee pain. There's warmth and tenderness. He is febrile, has an elevated CRP, and a negative joint aspiration. So in this scenario, they're trying to tell you that there is an infectious process going on, but it doesn't sound like it is septic arthritis because the aspiration is normal. And so the correct answer is 3, and most of you got that question right. This is clubfoot. 3-year-old boy has been treated in the past with Ponseti casting, now presents with dynamic supination during gait. You're planning to perform an anterior tibialis transfer to the lateral column, or the lateral cuneiform. All of the following are true except, so clubfoot is idiopathic in nature, although the genetics are still being worked out. There may be some familial association. Anatomically, it's hindfoot equinovarus, forefoot supination and adductus, and midfoot cavus. You can see this photograph of a child with bilateral club feet with the typical posture of the hindfoot, a supinated adducted forefoot, and it's difficult to see whether there's cavus there or not. So treatment consists typically of serial casting via the Ponseti method. And the Ponseti method emphasizes gentle manipulation in a stepwise fashion and correction of the deformities also in a stepwise fashion, starting with correction of the cavus and then progressing to correction of the adductus as well as the varus and equinus of the hindfoot last after abduction of 50 to 60 degrees is achieved. The casts are usually long leg casts. In fact, they're always long leg casts from hip to toes. And so the mnemonic cave is a good way to remember the order of correction. Serial casting is usually followed by tenotomy at 6 to 8 weeks after the initiation of casting, and then some form of abduction bracing for up to 2 to 4 years. Tibialis anterior transfer is a common procedure. It is necessary in 10 to 30% of patients who have feet that are treated in this method for recurrence, and typically occurs after the age of about 2, in the age range from 2 to 5 years. The things that you'll see clinically in a child who may need a tibialis anterior tendon transfer are that they will have lateral weight bearing. They'll also have tibialis anterior activity in both swing and stance phase. And they have to have a flexible deformity, so this is not an effective method of treatment if the deformity is not flexible. So knowing this, a 3-year-old who has previously been treated now has a recurrence with dynamic supination. You're planning a tib-ant tendon transfer to the lateral cuneiform, which is the usual site. The preferred response is 4, so this is an accept question. So all of the other answers are things that that are true. Subtalar rigidity is a contraindication to performing the transfer, and so most of you got that right as well. 16-year-old female complains of foot pain with ambulation. She previously underwent clubfoot soft tissue releases at 5 months of age. Each of the following are complications or late deformities associated with clubfoot surgery except. So this is a question that may be a little bit challenging for some of you because the Ponseti method has become so popular as a form of treatment that many of the post-surgical problems that we used to be seen quite commonly in pediatric orthopedics fortunately have gone away. But it's still important to know the answer to this question because there's still lots of patients out there. Post-surgical deformities include those that are due to undercorrection or recurrence, and that includes medial spin in in-toeing, as well as recurrent equinus, or the other family of problems that are seen as a result of treatment is overcorrection. And so overcorrection is typically a rigid flat foot deformity with hindfoot valgus, calcaneus gait, and weak push-off. In addition, because of the extensive nature of the release, there's damage to the vascular supply of the talus. There can also be an injury to the peroneus longus which results in a dorsal bunion and dorsiflexion of the first ray. Stiffness is common, as is pain. So knowing that, we see that dorsal bunion is listed as an answer for secondary deformity, as is osteonecrosis of the talus, rigid flat foot, in-toeing gait, but tarsal tunnel syndrome is a deformity that is not seen following surgical release of the clubfoot. I can see that only 35% of you answered that question correctly, and I think that's a reflection, as I said, of the fact that these patients are not as common as they used to be. But it's important still to know what kind of iatrogenic or post-surgical problems still occur. Next is femur fracture. Which of the following patients would be the best candidate for submuscular bridge plating? This is a question that really covers the topic of treatment of femur fractures in the ambulatory child or the child who is school age. So children between the ages of 5 and 11 have a variety of treatment options for treating their femur fractures. And the decision-making criteria isn't always straightforward. And making these decisions depends on a variety of factors, including the age and maturity of the patient, the weight of the patient, the length stability of the fracture, the location of the fracture, whether it is proximal third, diaphyseal, or distal third, and the presence or absence of polytrauma or multiple extremity injuries in one patient. Last, surgeon comfort is an important thing to consider as well, because obviously whatever is most facile in your hands and that you can do well is probably the best choice for the patient. So this is an example of a submuscular bridge plate, which is one of the options for a length unstable fracture. So length unstable fractures are those with comminution or a large oblique fracture pattern. And these typically are treated with open reduction internal fixation with plating, minimally invasive or submuscular plating, as well as possibly external fixation, and occasionally in the upper ends of this age range or in the larger children with reamed rigid intramedullary nails that have a trochanteric starting point. So back to the question, the best candidate for submuscular bridge plating, you can see the preferred response is 3, which is a child who's in the upper age limit, who is above the nail or above the weight restriction that's recommended for treatment using flexible intramedullary nails, but also with a length unstable fracture that requires an implant that's going to hold it out to length. So 3 is the correct response, and most of you got that right. Next, medial epicondyle fractures. A physician from an emergency room at a referring hospital calls you about a pediatric patient with a closed elbow dislocation. Which of the following fracture patterns, figures A through E, is most commonly associated with a pediatric elbow dislocation? So you can see here that they have a variety of injuries represented. The first x-ray on the left is an example of a supracondylar humerus fracture with perhaps an associated lateral condyle fracture. The next is a medial epicondyle fracture. You can see that the medial epicondyle is displaced in an older child. The one next to that, moving from left to right, is a displaced type 2 supracondylar humerus fracture, which is an extension type injury there. Above that to the right is a badly displaced type 3 supracondylar humerus fracture. And below that is a Montesia fracture with a proximal ulnar shaft fracture and an associated anterior radial head dislocation. So medial epicondyle fractures result from an avulsion by the flexor pronator muscular wad. And they have some controversy regarding treatment of these types of injuries. Open reduction internal fixation is indicated for those injuries that have been entrapped in the joint following an elbow dislocation. An elbow dislocation is a common associated injury with this type of fracture. And in fact, anytime an elbow dislocation is recognized in a child, you have to be concerned that there might be an associated medial epicondyle fracture. The true displacement is usually seen on an oblique film. This is usually an internal oblique x-ray. You have to be aware that the ulnar nerve may have been dragged into the joint after reduction of the elbow if the fragment is contained within the joint as well. Displacement of 2 to 10 millimeters has been cited as an indication for treatment, so there's quite a bit of variety and really no consensus on how much displacement is enough to necessitate treatment, and it depends a lot on the activity as well as the hand dominance of the injured child. So you can see these x-rays, the two above show an elbow dislocation that has been reduced with the medial epicondylar fragment visible within the joint. And you can see the capitellar ossification center, which is normal, and just medial to that is the medial epicondyle fragment, which is entrapped within the joint. And on the lateral x-ray, you can see as well that the medial epicondyle fracture, which should be posterior on that lateral film, at the level of the bottom of what appears to be the hourglass pattern of ossification in the distal humeral metaphysis, is at the level of the capitellum and within the joint. And below you can see the C-arm images after this fracture has been reduced, and the elbow is now concentrically reduced as well. And you can see just a hint of an air arthrogram as well, just distal to the capitellum on the AP and the lateral views. Back to the question, the pediatric patient with an elbow dislocation, which fracture pattern is associated with it, and we now know that that is a medial epicondyle fracture, and you can see another example of that on this x-ray with the medial epicondyle being outlined by the black arrow and its normal bed being outlined by the white arrow, as well as the presence of this fracture dislocation. About 2/3 of you got that question right. The most common wrong answer was the Montesia fracture. It's just important to know that what they're talking about is true elbow dislocation of the ulnohumeral joint and not a radial head dislocation. Next is lateral condyle fractures. An 8-year-old boy falls on his right upper extremity and presents to the emergency room with the radiographs shown in figures A and B. He has exquisite tenderness to palpation along the lateral aspect of his elbow. What additional radiographic view will likely demonstrate the maximum degree of fracture displacement? As you can see on the radiographs that are provided, it's not clear-cut exactly what the injury pattern is. The radial head is well aligned with the capitellum. The proximal ulna is well aligned with the distal humerus. The medial epicondyle appears to be in its appropriate position. You can see just a hint of a fracture line in the metaphysis proximal to the capitellum and the lateral condyle, which many times on the AP film is very difficult to detect. Similarly, on the lateral x-ray, it's very difficult to see the displacement of the fracture. The lateral condyle fractures are the second most common fractures around the elbow in children. They are really divided into those fractures that have an articular hinge, which keeps them non-displaced or minimally displaced and makes it a stable injury, versus those where the fracture line extends from the metaphysis all the way into the joint across the articular surface. And so this is a displaced intra-articular injury with synovial fluid bathing it, and so this is at high risk for non-union. So X-ray evaluation of lateral condyle fracture should include internal rotation oblique images as well. An MRI or an arthrogram can be useful to visualize that hinge. Initial treatment for those minimally displaced injuries can be splinting followed by casting with frequent follow-up and very close follow-up. In fact, they should probably be x-rayed weekly until you can see bridging fracture callus over the metaphysis. Displaced fractures typically require open reduction and internal fixation through a lateral approach. Posterior lateral dissection should be avoided, as this is the source of the blood supply of the distal lateral humerus and the lateral condyle. The complication that's most commonly described in this, or most commonly talked about, although it's not the most common complication, is non-union, which leads to cubitus valgus and subsequent tardial ulnar nerve palsy. you can see that once again, the child with the lateral condyle fracture, which view will show his fracture displacement the greatest, and it's the internal oblique radiograph. And you can see that answer 2 was achieved by about 2/3 of you. About 1/3 of you said the external oblique radiograph, and that's just one of those things that needs to be, that you have to commit to memory. Next is infantile Blount's disease. 32-month-old male with severe infantile Blount's disease has been treated with full-time bracing for the past year. At most recent follow-up, the varus deformity of his bilateral legs has worsened despite compliance with bracing. What treatment is now recommended? So infantile Blount's disease is progressive infantile tibia vera. It affects the proximal medial tibial physis and epiphysis. Typically, the onset is prior to 3 years of age. The hallmark is that it is a progressive worsening of their pre-existing genu verum that most children are born with. Langenschuld classification has been described to describe not necessarily the severity of the injury, but the maturity of the patient as well. And so by Langenschuld's criteria, type 1 are those children who are very early in the process and may have just some medial beaking without a true step off of the metaphysis. Type 2 shows a step off of the metaphysis. Type 3 starts to show some ossification and drooping down of the epiphysis. Type 4, 5, and 6 are showing progressive deformity and bar formation of the proximal medial tibia. The metaphyseal-diaphyseal angle as described by Drennan is useful and is really a measure of the obliquity of the proximal metaphysis relative to the proximal tibial shaft. An angle greater than 13 is representative of a situation where the child needs continuing follow-up. Greater than 16 has been described as children who are all destined for progression. Those less than 11 almost all resolve. So surgical treatment for infantile Blount's disease is indicated in those patients who have failed bracing, those children who are Langenschuld stage 3 or greater, or unresponsive or with late presentation despite no bracing. These children will have best results if their proximal tib-fib osteotomy is done before the age of 4. Technically, the osteotomy should be done to overcorrect the proximal tibia into valgus of 5 to 10 degrees. In addition, because many times these children have associated internal tibial torsion, rotational correction is necessary. Because of the high risk of compartment syndrome due to the proximity to the proximal calf vasculature and the recurrent vessels to the interosseous membrane, a prophylactic anterior compartment or four-compartment fasciotomy should be performed. Older children or children who've had recurrence may need physeal bar resection as well. Getting back to the question, a less than 3-year-old child with severe Blount's disease has failed bracing. And now the next step in treatment is bilateral proximal tib-fib osteotomies, and that's response number 3, and most of you got that right. Next is distal femoral physeal fracture. An 11-year-old boy underwent surgical intervention for the injury shown in figure A 2 years ago. He currently does not complain of knee pain, but the parents have noticed a progressive bow leg deformity. Physical examination reveals 5 degrees of varus relative to the contralateral side. Current radiographs are provided, figure B. Physeal mapping via CT demonstrates a bar involving 25% of the physis. The remainder of the physis is open. Which of the following is the most appropriate treatment? So the radiograph on the left in figure A shows a Salter-Harris 2 injury to the distal femoral metaphysis that's displaced. And you can see there's a large Thurston-Holland fragment laterally. This after treatment, which was treatment with reduction and some type of fixation, shows that there is a varus deformity with continued growth laterally, but a asymmetric growth arrest medially. Distal femoral physeal injury is more common than ligamentous injury in children because of the epiphyseal ligamentous attachment of the distal femoral physis. So the cruciate and the medial and lateral collateral ligaments all attach in the epiphysis and do not bridge the physis. Thus, a traumatic injury in this region results in physeal fracture and not ligamentous injury in most cases. MRI and ultrasound are useful for identifying displacement of the fracture or fractures that may be displaced and then spontaneously reduced. Stress radiographs are still occasionally used, although MRI and ultrasound are more frequently used now. You have to understand there's a very high incidence of physeal arrest with these injuries, and up to 30 to 50% of these injuries can lead to physeal arrest. If this is a non-displaced injury that is stable, closed reduction and long leg casting can be appropriate. Most cases require reduction and pinning. The pinning can be extraphyseal if possible with a large Thurston Holland fragment like the case that was displayed. If it is a Salter-Harris 1 type injury or a Salter-Harris 2 with a small metaphyseal fragment, then smooth pin fixation that crosses the physis is appropriate. Now, physeal arrest is something that can be treated in a variety of ways, and it depends on the nature of the arrest and the age of the child. So partial arrest typically results in an angular deformity, and so partial arrest is amenable to bar resection if there's greater than 2 centimeters of growth remaining and less than 50% of the physis is involved. If there's greater than 50% physeal involvement or less than 2 centimeters of growth remaining, then it's probably best to proceed with completion of the growth arrest and contralateral epiphysiodesis. And depending on the age of the child, this may lead to either a leg length discrepancy that might require lengthening versus epiphysiodesis to equalize leg lengths. You can see on the radiograph here a distal tibial physeal bar that has undergone resection and restoration of alignment and continued growth. Back to the question, an 11-year-old boy who had a distal femoral physeal injury with a resultant asymmetric growth arrest and now has 25% of his physis that is closed, which is less than the criteria that would be an indication for continuing with treatment by resection, and he has greater than 2 centimeters of growth potential. So I think this is one that would be a good candidate for a physeal bridge resection with PMMA interposition. And the PMMA is there to occupy the space around the physis, and it's used to maintain a growing physis and a marker for growth as well. Next are distal radius fractures. An 8-year-old boy fell while riding his bike and landed on his outstretched arm. Radiographs are provided in figure A. Which of the following increases the risk of displacement following closed reduction and casting? Distal radius fractures can be classified into those that are intra-articular and extra-articular. Extra-articular Salter-Harris fractures are typically amenable to closed reduction and casting with a good interosseous mold of the cast. And so the interosseous mold is an important feature to be aware of when you're talking about treatment of distal radius as well as forearm fractures. So the interosseous mold can be measured by looking at the cast index, and the cast index is simply a measure of the cast width in the AP plane relative to the cast width in the lateral plane, and it should be skinnier in the lateral plane by about 20% than it is in the AP plane. Intra-articular Salter-Harris fractures typically require open reduction and internal fixation. Torus or buccal fractures can usually be treated with either a short arm cast or even removable splinting. Green stick fractures typically require a reduction if there's greater than 10 to 15 degrees of deformity, as this does not remodel. So back to the question, the boy fell and landed on his outstretched arm and sustained a distal radius fracture. The likelihood of Placement depends on good interosseous mold, so a cast index, which is greater than 0.85, increases the risk of that fracture displacing. About half of you got that answer right. The other half answered that a long arm cast was necessary and a short arm cast was a poor choice for this kind of an injury. But I think the literature reflects the fact that short arm casting is appropriate for these types of injuries if it is a well molded and well placed cast with a low cast index. Next, cerebral palsy. In patients with cerebral palsy, voluntary control of motion best predicts improvement in function after which of the following? So in the upper extremity of children with cerebral palsy, there are some characteristic deformities. These include shoulder internal rotation, elbow flexion contracture, pronation contracture of the forearm, wrist flexion and ulnar deviation deformity, thumb and palm deformity, as well as swan neck deformity of the fingers. The reasons to treat in these patients include improvement of hygiene in those kids who have severe contractures of the elbow, which causes skin maceration and breakdown in the antecubital fossa, or of the wrist and hand, which can cause similar problems in the palm. The other reason to treat for these children is to improve function, and the ability to improve function is relative to the ability of the child to cognitively participate in occupational therapy as well as to control their own muscular movements. It increases the utility of that hand as a helper hand if they have better control and better cognition. So getting back to the question, knowing that, we see that the correct response is answer number 3, that the child who has voluntary control is amenable to surgery and tendon transfer of the wrist and hand, and their prognosis is good, and their chances for a good outcome are quite good as well. Next is Duchenne muscular dystrophy. A 9-year-old boy with Duchenne muscular dystrophy has increasing difficulty with ambulation. He denies back pain, difficulty sitting in a chair, or shortness of breath. Annual screening spine radiographs demonstrate a 20-degree thoracolumbar curve. Which of the following statements best describes the appropriate treatment plan for his scoliosis? Duchenne muscular dystrophy is a X-linked recessive disorder that has scoliosis as a large component of the deformity. The scoliosis and spinal deformity that we see in these children typically progresses after they become wheelchair dependent. Children who are developing spine deformity are traditionally fused early because of their lower risk of surgery, the smaller magnitude of the operation, and the fact that they are able medically to survive the operation and avoid complication more easily. So typically these curves are fused prior to reaching 30 degrees in magnitude. The early fusion improves the quality of their life, but it does not increase the length of their life. You can see on the right a picture of Gower's sign, which is one of the hallmark physical examination findings. And the other things that you'll notice in a child who has Duchenne muscular dystrophy is that they have decreased motor skills, and they start out essentially with normal skills as an infant, but then with age up to about 2 to 6, they develop worsening skills, and they lose the ability to keep up with their peers. Calf pseudohypertrophy is one of the common findings. Gower's sign we discussed, and the lab finding that is pathognomonic is a markedly elevated CPK. So back to the question, you can see that the preferred response is number 2, spinal fusion prior to the progression of the curve beyond 30 degrees. The other options are indications for surgery in idiopathic scoliosis, as well as one of the answers talks about forced vital capacity, and it's important to know that it's good to operate on these children before their forced vital capacity or their pulmonary function deteriorates. Humeral physeal separation. 10-month-old child fell off the couch and has left elbow pain and swelling. A radiograph is shown in Figure A. All of the following are characteristics of this injury pattern, except the distal humeral physeal separation happens in young children and is associated with abuse or battery. It can be very difficult to diagnose, and sometimes an arthrogram is necessary in order to make the diagnosis. It looks like an elbow dislocation and is frequently mistaken for this. The only sign can be posterior medial displacement of the forearm relative to the distal humerus. In those injuries that are minimally displaced or non-displaced, a posterior splint and long arm cast are appropriate for treatment. For those displaced injuries, they're treated like supracondylar humerus fractures with closed reduction and percutaneous pinning. You can see on the radiograph here the radiographic findings that we discussed, that the proximal ulna and the proximal radius are in appropriate relationship to one another, but both of them seem to be dislocated from the distal humeral metaphysis. Once again, a 10-month-old child who falls off the couch has left elbow pain and swelling. The radiographs show a distal humeral physeal separation. There is a risk in this type of a fracture for tardy ulnar nerve palsy. So the preferred response is 1. There's a lot of disparity in how this question was answered, and I think that there may be some more information that will be discussed later on about this question. Next is flexible flat foot. Flexible flat foot. So the question is, a 12-year-old boy has 2 years of right foot pain that prevents participation in athletic activities and is symptomatic with walking. He has attempted UCBL and custom orthoses for 1 year with no relief of symptoms. His hind foot is supple, and he has full dorsiflexion. Clinical images of the foot are shown, figures A and B. A lateral radiograph is shown in figure C. A surgical plan to address the deformity would most appropriately include which of the following? You can see here there are clinical pictures of hind foot in valgus and a lateral view of the foot with a diminished arch. You can also see the radiograph that shows a midfoot sag and the talo first metatarsal relationship, which should be collinear, shows a break and a sag in the midfoot. You can also see as well that there's flattening of the calcaneal pitch, and the calcaneus is in a little bit of a flexed position. So a flexible flat foot is characterized by a low medial arch, a valgus heel with forefoot abduction. There is normal subtalar motion in most of these children. If there is not normal subtalar motion, then you have to look for an underlying etiology like tarsal coalition or some other process that is irritating the subtalar joint or limiting subtalar motion. And typically these children don't have heel cord contracture, but occasionally they can if they are symptomatic, but in flexible flat foot, usually not. Operative treatment for this deformity is rarely indicated, and typically these patients have to fail conservative methods of treatment prior to progressing to any type of surgical treatment. Conservative methods include stretching of the gastroc-soleus complex, as well as the use of orthotics. The most common surgical procedure is a calcaneal neck lengthening osteotomy. Sometimes this can unmask tightness of the Achilles tendon, which is then necessary for lengthening afterwards. And then medial cuneiform osteotomy may also be necessary if the first ray remains supinated, and a dorsal opening wedge osteotomy restores the first ray relationship. So back to the question, a 12-year-old boy has 2 years of right foot pain that prevent participation in athletic activities. He's attempted and failed bracing. His hind foot is supple, and he has full dorsiflexion. So the preferred response is number 4, calcaneal neck lengthening osteotomy About 2/3 of you got that right. Lateral calcaneal slide osteotomy is indicated for varus hindfoot deformity. The other answers were infrequently chosen, but the preferred response is number 4. Both bone forearm fracture. 12-year-old boy fell sustaining a both bone forearm fracture. Which of the following is true regarding the radiographic assessment of anatomic forearm alignment after reduction? Both bone forearm fractures are quite common. They can typically be treated closed with closed reduction and casting. It's important to know the criteria to look for radiographically to outline a acceptable reduction. And usually those criteria include less than 5 degrees of deformity in the AP view and less than 10 degrees of deformity in the lateral view. Up to about age 10, these are acceptable criteria. Also, somewhere in the neighborhood of 20 to 30 degrees of rotational deformity seems to be well tolerated by patients. Now, a rotational guide on the AP view is that the radial styloid should be opposite the bicipital tuberosity, and this is 180 degrees opposite. So on the AP view, you can see after reduction and healing on those right 2 films, the bicipital tuberosity is pointing medially, and the radial styloid is pointing laterally, and they're 180 degrees from each other. On the lateral view, you can see that the ulnar styloid is opposite the coronoid process, and on the far right radiograph, you can see that that's the case as well. Back to the question, the 12-year-old boy fell, sustaining the both bone forearm fracture. Which parameters tell you that they are anatomically aligned? And once again, the preferred response is 4, and you can see that the radial styloid and the tuberosity are 180 degrees apart on this AP film. About 60% of you got this question right. About 30% answered 5, and that's the radiograph and the radial styloid and tuberosity are 90 degrees apart when it's actually 180 degrees. They should be on opposite sides of the bone.
Shirley from the Moores Children's Clinic in Jacksonville, Florida, and I'm going to review the next set of questions. The first topic will be leg length discrepancy. A 14-year-old boy sustains a significant distal femoral physeal fracture. Assuming that he has a complete growth arrest, what is the predicted leg length discrepancy? In order to answer this question, you need to know about predicting limb length discrepancies and normal lower extremity growth. The methods to project limb length discrepancy at maturity include the arithmetic methods, the growth remaining method, the Moseley straight line graph, and the multiplier method. The arithmetic method makes a few assumptions about lower extremity growth. These include that the magnitude of growth of the proximal femur is 3 millimeters per year, that the distal femur is 10 millimeters per year, the proximal tibia is 6 millimeters per year, and the distal tibia is 5 millimeters per year. And these growth magnitudes continue until growth stops at age 16 in boys and 14 in girls. So knowing that the distal femur physis grows 1 centimeter per year and that there is 2 centimeters or 2 years of growth remaining, you are able to select choice 2, and almost everyone got that answer correctly. The next topic is the accessory navicular. An 18-year-old male complains of a painful prominence over his medial midfoot for the past 2 years. Anti-inflammatories and orthotics have failed to provide relief. Physical exam demonstrates a firm, non-mobile, tender bump on the medial midfoot with no skin changes. A radiograph is provided in Figure A. Which of the following is the best treatment option? So, this question requires you to make the diagnosis from the radiographs and know the appropriate treatment. The radiographs show an accessory navicular in a skeletally mature patient. This is a normal variant seen in up to 12% of the population. It's often associated with pes planus, and it might cause medial arch pain. And if it does, the first-line treatments are non-operative. operative treatment is indicated after 6 months of non-operative attempts, and this involves excision of the accessory navicular. Rerouting or advancement of the posterior tibialis tendon does not approve an associated flat foot. In order to correct that, you would need to do additional techniques. So knowing this information about the accessory navicular, you are able to select choice 5, surgical excision, and almost everyone made that response. The next question is radial head subluxation, or nursemaid's elbow. A 3-year-old boy holds his elbow in a flexed and pronated position and refuses to use it after his mother caught him by the hand as he fell down some stairs. The child will not rotate the forearm and clenches his elbow. Radiographs are negative for fracture. What is the most appropriate course of action? In order to answer this question, you need to recognize from this vignette that the patient has a nursemaid's elbow. This is due to longitudinal traction on the extended arm, which results in interposition of the annular ligament in the radiocapitellar joint. The arm subsequently rests in flexion and pronation. The radiographs are often normal, although they might show slight translation of the radial head, but not a true dislocation. Treatment consists of reduction by supinating the forearm and flexing the elbow. You want to position your thumb over the radial head in order to feel the reduction of the annular ligament. Therefore, the answer to this question is number 3, closed reduction in elbow flexion and supination. And again, most respondents made the appropriate answer. The next topic is tibial tubercle fractures. A 14-year-old boy sustains the injury shown in Figure A. He subsequently develops compartment syndrome and requires fasciotomy. Injury to what artery is most likely responsible? The radiographs demonstrate a tibial tubercle fracture, which is markedly displaced in a nearly skeletally mature patient. So this is a common fracture in adolescent boys. The proximal tibial physis closure begins centrally and then progresses to the tubercle. And treatment consists of ORIF for displaced fractures in order to restore the extensor mechanism. Complications include recurvatum deformity and compartment syndrome. Compartment syndrome is due to an injury of the anterior tibial recurrent artery from the tubercle fracture. This artery arises superiorly to supply the anterior knee. Therefore, you should consider a prophylactic anterior compartment fasciotomy when performing open reduction internal fixation of these fractures. Knowing this information, you are able to select choice 5, anterior tibial recurrent artery, and the majority of the respondents had the answer. The next topic is cavo-varus foot. What is the preferred orthotic device for a symptomatic adult foot deformity that is shown in Figure A, has no arthritis on radiographs, and responds to Coleman block testing as shown in Figure B? Figure A demonstrates a cavus foot, which also has hindfoot varus, and Figure B shows the correction of that hindfoot varus. A cavus foot is an elevation of the medial arch from relative forefoot equinus. It is caused by spasticity of the contracted plantar fascia and weakness of the tibialis anterior. There are multiple neurologic causes which require further evaluation, and these include Charcot-Marie tooth, Friedreich's ataxia, spinal cord lesions, cerebral palsy, and polio. The Coleman block test evaluates the flexibility of hindfoot varus. What you do is place a block under the lateral foot in order to eliminate the contribution of the plantar flexed first ray. And therefore a flexible varus hindfoot will correct to neutral, while a rigid will not. Non-operative treatment consists of an orthotic, which corrects the hindfoot varus via lateral post and includes a depression for the first ray. So knowing this information about the cavo-varus foot, you are able to select choice 5. Some were confused about the medial versus lateral hindfoot post, but remember it's the lateral post which will correct the hindfoot varus. The next topic is internal tibial torsion. A 2-year-old boy is brought to your clinic by his mother for being pigeon-toed. Each of the following measurements found on physical exam are a routine part of the lower extremity profile, except both figures A and B demonstrate measuring the thigh-foot angle. Figure C measures the Q angle. Figure D is a measure of the heel bisector. And figure E is the foot progression angle. Remember that the rotational profile consists of the following: the foot progression angle, which is a measure of the overall alignment of the lower limb, or rotation, and is observed by watching the child walk and is the angle between the foot and a straight line. Hip rotation, which is an estimator of femoral aneversion, with increased hip internal rotation being a sign of increased hip femoral aneversion. And then the thigh-foot angle and the transmalleolar axis, which are both measurements of tibial torsion. And finally, the heel bisector test is a measurement of metatarsus adductus. Remember about internal tibial torsion that this is due to intrauterine positioning, that parents might note tripping, but there's no evidence that these are correlated, and bracing does not change the natural history. And this typically resolves by ages 4 to 8 years. So because the Q angle is not a part of the lower extremity rotational profile, the correct answer is C. The next topic is pediatric tibia fractures. A 3-year and 6-month-old child fell while playing with his friends 2 hours ago and has avoided bearing weight on the right leg since that time. The child is afebrile, and exam reveals tenderness along the distal tibial shaft with no significant swelling. Radiographs are shown in figures A and B. What is the most appropriate treatment? The radiographs here demonstrate a non-displaced tibial shaft fracture. Now, toddler fractures of the tibia can occur after minimal trauma. They're often non-displaced with an intact fibula, and they can be treated with cast immobilization. With toddler fractures, the initial radiographs are often negative. However, you should immobilize the patients in a cast if a fracture is the most likely diagnosis. Keep infection in the differential and evaluate for osteomyelitis with labs and other studies at the initial visit if the child presents with signs of infection, or at the follow-up if you don't see any callus on the radiographs. So recognizing that the radiographs demonstrated a tibial shaft fracture and knowing that minimal trauma is required to cause this fracture, you are able to select for long leg cast application. The next topic is septic arthritis of the hip. An 8-month-old infant is brought by his parents to your office for fever and malaise. Your inspection of the patient is detailed in Image A. An oral temperature of greater than 38.5 degrees Celsius has been found to be the best predictor of this child's condition. What is the second best predictor? So the best predictors of the septic hip, in order, are fever, CRP greater than 2, ESR greater than 40, an inability to bear weight, and an elevated white blood cell count. And these are based out of a study from the Children's Hospital of Philadelphia. And you sort of need to know this specific study in order to answer the question. Remember with septic arthritis that inoculation results from hematogenous or directly from the bone. In the neonates, there are transphyseal vessels which can cause the infection. And remember the joints with an intra-articular metaphysis, and these include the hip, the shoulder, the elbow, and the ankle. Also remember the common bacterial causes. In patients less than 12 months, the nosocomial cause is Staphylococcus, and the community-acquired cause is Group B Streptococcus. In 2 to 12 years of age, the most common cause is Staphylococcus. And in adolescents, the most common cause is Neisseria gonorrhea. So, knowing these best predictors of the septic hip, you are able to select answer 4. And this was a difficult question, and unfortunately one that essentially requires you to know that specific paper by Carrot et al. Fortunately, there are a lot of questions on tests that do not require you to memorize a specific paper. The next question or topic is brachial plexus injuries. An infant is born with total brachial plexus palsy and Horner syndrome after a difficult vaginal delivery. What is the prognosis for spontaneous recovery of motor function in the involved arm by 3 months of age? So this question requires you to know about brachial plexus injuries. These are not very common at 1 in 3,000 births and are due to a stretch or contusion. 90% of cases will resolve without intervention. Most cases can be observed with passive motion because of those good results. The worst prognosis is seen with total plexus injuries, especially when this is associated with a preganglion injury and a Horner syndrome, and these will have less than a 10% chance of spontaneous recovery. Remember the common types of brachial plexus palsy: ERBs or upper trunk, Klumpke's or lower trunk, and total plexus. Early surgery is for the complete flail arm or Horner syndrome, and this is done with microsurgical nerve repair or nerve grafting. Later surgery consists of tendon transfer or osteotomies for internal rotation contractures of the shoulder or pectoralis transfers for decreased elbow flexion. Knowing this information about brachial plexus injuries, you are able to select choice 5. The next question is radial neck fractures. A 12-year-old boy falls 8 feet from a tree limb and lands on his outstretched hand. He complains of elbow pain, and a displaced radial neck fracture is located on the radiographs. Closed reduction is attempted with sedation, and post-reduction radiographs are provided. Which of the following actions should be taken? So the radiographs demonstrate a radial neck fracture with greater than 45 degrees of angulation. Radial neck fractures often occur with other injuries and can result in a flipped radial head, which you want to be sure to identify. Treatment is primarily based on angulation. If there is less than 30 degrees of angulation, these should be immobilized. If there is more than 30 degrees of angulation, closed reduction should be performed, and there are multiple techniques described. After your closed reduction attempt, surgery is indicated for greater than 30 degrees of residual angulation or 5 millimeters of translation. This can be done percutaneously with the K-wire or the metazo method. Open reduction can be performed if this percutaneous method or further closed reduction attempts in the OR are unsuccessful. The exact indication for an open reduction is not well determined, but ranges between 30 and 60 degrees of angulation. Fixation should be performed if the reduction is unstable, and this is not always necessary. In general, you want to minimize your duration of immobilization and reduce the fracture without opening the fracture in order to decrease your risks of stiffness. So, knowing the tolerances for radial neck fractures, you are able to select choice 5, operative reduction and fixation. This does not necessarily mean open reduction. It just means closed reduction or percutaneous reduction in the OR after your initial attempt outside of the OR has failed. The next topic is growth and proximal humerus fractures. Which of the following answers represents the ratio of growth from the proximal and distal growth plates in a humerus, respectively? So this requires you to know the individual contributions of growth plates to the normal upper limb growth. Limb growth in the arms is 40% from the shoulder, 20% from the elbows, and 40% from the wrist. Bone growth in the humerus is 80% proximal, 20% distal, and the forearm is the opposite of this. So therefore, with proximal humerus fractures, you have enormous remodeling potential, and almost any amount of displacement and angulation can be accepted in a child with an open physis, whereas in children greater than 12 years of age, you want less than 40 degrees of angulation, or between 1/2 and 2/3 of displacement. For the lower limb, in general, remember that growth occurs at the knee, and remember for the upper limb that growth occurs away from the elbow. Therefore, knowledge of the humerus growth pattern allows you to select number 1, 80:20, and the majority of you were able to get this correct. The next question is about pediatric resuscitation. A 5-year-old girl presents after being struck by a vehicle in her driveway. She has multiple injuries, including a right femur fracture, open book pelvis, bilateral clavicle fractures. Peripheral IV access cannot be obtained in the trauma bay, and the patient's blood pressure is 110/70. Which of the following is the most appropriate method to obtain vascular access? So you need to recognize that the patient is hypotensive and does not have peripheral access. In addition, the patient has clavicle fractures, which are certainly problematic for subclavian lines. So interosseous lines for pediatric trauma are actually the line of choice in patients less than age 7 when peripheral access can't be obtained. In older patients, the harder bone makes this more difficult to obtain. They're easily inserted and they have low complication rates. Other key points about pediatric trauma are that this is the most common cause of death in children, and that CNS injuries have the highest morbidity and mortality among all injuries, that spine fractures have the highest morbidity and mortality among musculoskeletal injuries, and that children can remain hemodynamically unstable even after significant blood loss. And remember that pediatric blood volume is about 75 milliliters per kilogram. So, knowing that the interosseous line is a safe option, you are able to select number 1, placement of an intraosseous infusion device. The next topic is the elbow. Which of the following elbow apophyses is the last to fuse during growth? So this requires you to know about the maturation of the pediatric elbow, whereas almost everyone remembers the order of appearance of the apophyses. So the fusion of the elbow occurs as follows. The capitellum, lateral epicondyle, and the trochlea form one epiphyseal center at age 10 in girls and 12 in boys. And this center fuses with the distal humeral metaphysis at 13 in girls and 15 in boys. The medial epicondyle is the last part to fuse with the metaphysis, and that occurs at 14 in girls and around 17 in boys. What most remember is the order of appearance of the elbow growth centers. Capitellum, followed by radius, followed by medial epicondyle, then trochlea, then olecranon, and then the lateral epicondyle, with about 2 years of range between males and females. So knowing the order of closure of the elbow apophyses, you are able to select number 4, medial epicondyle. And this was a really hard question, with the majority of the respondents selecting the external epicondyle, because again, I think most of us remember the order of appearance and not the order of closure, and hopefully those slides have made those facts more clear. The next topic is sickle cell anemia. A 3-year-old African American child presents with irritability, fever, and a warm swollen leg. Imaging shows an area concerning for osteomyelitis, and transcortical biopsy reveals multiple Salmonella species. This child most likely also has which of the following conditions? This question requires you to know the orthopedic manifestations of sickle cell disease. These include osteomyelitis, septic arthritis, dactylitis, which is acute hand and foot swelling, osteonecrosis, bone infarcts, and growth retardation. Osteomyelitis can certainly occur in sickle cell patients, and when it does, Staph aureus is the most common cause, while salmonella is the most characteristic cause, and this occurs from seeding from the gallbladder infections or bowel necrosis. Remember when these patients present that the ESR may not be elevated. Another diagnostic fact is that radionuclide bone and bone marrow scans can be helpful for the diagnosis, as osteomyelitis will show an abnormal bone scan but normal marrow uptake, but this is decreased in infarcts. So, knowing the causes of osteomyelitis in patients with sickle cell disease, you are able to select number 4, sickle cell anemia.
Last section in pediatrics, there'll be 18 questions, the first of which is regarding leg Calvé-Perthes disease. A 6-year-old boy presents with left leg pain and limping. Radiographs are shown in figures A and B. The radiographic changes necessary for accurate lateral pillar classification of his disease are usually evident how long after the onset of symptoms. Below what we have is the AP pelvis and frog lateral hip radiographs of this 6-year-old boy. You can see the typical stigmata associated with Perthes disease involving the left capital femoral epiphysis, where you have shortening of the lateral pillar, consistent with early Perthes disease. Let's go into what we need to know to answer this question. Perthes is very common, affects boys more than girls, and usually between the ages of 4 and 6. Lateral pillar classification has significant prognostic value. The best time to make lateral pillar classification on radiographs is in the early fragmentation phase, which is typically at about 6 months after onset of symptoms. Lateral pillar classification is A, B, and C, with A being no loss in lateral pillar height, B being up to 50% loss in height, and C more than 50% loss in height. Let's go back to the question. What this question is really asking is, at what phase in Perthes disease can you make an accurate lateral pillar classification? The correct answer, or preferred response, is 3 or 6 months, and I see that 54% of you got this question correct. A third of you picked number 2, which is 3 months of age, or 3 months into onset of symptoms. This is just one of those typical things that you need to know, a piece of information that you need to know in order to answer this question correctly. Next topic is Sprengel's disorder. A 4-year-old boy with Klippel-Feil syndrome has elevation of the left scapula since birth. Spine radiographs show no evidence of scoliosis. What shoulder motion is likely to be most limited? Again, let's go through some typical findings in Sprengel's deformity. First of all, it's very commonly associated with Klippel-Feil syndrome. It's a failure of scapular descent and can mimic scoliosis, as you can see in the 2 patients on the right-hand side of the slide. There are commonly also associated upper extremity anomalies. Typically presents with a high, smaller scapula and mimics scoliosis due to the asymmetry associated. As you can see in the slide's photographs on the bottom half of this slide, abduction is most severely limited, as depicted in the central and right-sided slide. The treatment is typically observation, but you can do resection if there's no move vertebral bone in order to bring the scapula down to its normal position, thereby improving its functional capabilities. Back to the question, a 4-year-old boy with Klippel-Feil syndrome has elevation of the left scapula since birth. Spine radiographs show no evidence of scoliosis. What shoulder motion is most likely to be limited? You guys did fantastic on this question, where 83% of you picked the correct answer, which is abduction, answer number 2. Posterior medial bowing of the tibia. An infant is born with a unilateral lower extremity deformity. A clinical photo is shown in figure A. Radiographs are shown in figure B. Which of the following conditions are associated with this type of deformity? As you can see in the photograph of the child in the lower left, this is a very alarming or stark appearing deformity, which can be alarming to the family, as well as the treating physician if they're not aware of the disorder. In the AP and lateral radiographs seen on the right-hand side of the slide, you can see definite posterior and medial bowing of this lower extremity. For posterior medial bowing, you need to know that there's an associated calcaneovalgus foot position, often even more severe than you saw on the previous slide. The typical findings is that this will spontaneously correct. With time, occasionally the foot will need to be casted, but rarely. Almost always it will resolve spontaneously. The most prevailing thing to find with posterior medial bowing of the tibia is about a 2 to 5 centimeter limb length discrepancy at skeletal maturity, as you can see in this child, as an infant on the left or toddler on the left, and as an adolescent on the right. Back to the question, what they really want to make sure you understand is that this is not something that's related to suited arthrosis of the tibia like anterolateral bowing would be, and instead a residual limb length discrepancy, and you guys did an excellent job on this with 75% of you getting the correct answer. Mucopolysaccharidoses. Children with lysosomal storage diseases have increased rates of which of the following disorders? Syringomyelia, pectus excavatum, micrognathism, carpal tunnel syndrome, and thoracic kyphosis. Essentially what you need to know in any mucopolysaccharidosis is that it's a storage disorder. So therefore they're going to have lots of whatever the byproduct is that needs to be stored throughout the body. The tissue affinity depends on the proteoglycan and thus accounts for the variable clinical manifestations. All of these patients have increased risk for carpal tunnel syndrome because of these storage issues. Hurler syndrome leads to dermatan sulfate accumulation. Sanfilippo's heparin sulfate accumulation, and Morquio's keratin sulfate accumulation. Back to the question, as a general question regarding mucopolysaccharidoses, because they're storage disorders, they tend to build up in areas where there is free space, if you will, such as the carpal tunnel, and can lead to things causing nerve compression like carpal tunnel syndrome. 54% of you got this answer correct. 5% of you picked, 23% of you picked answer 5, which is thoracic kyphosis. That's an excellent guess, if you will, because there is a lot of spinal deformity associated with mucopolysaccharidosis, but not specifically thoracic kyphosis. So once again, carpal tunnel syndrome is the right answer. Cleidocranial dysostosis. An 8-year-old boy presents with an extreme shoulder motion and frontal bossing. Chest radiograph and AP pelvis radiograph are shown below. What is the most likely diagnosis? Let's first skip to the chest x-ray. For an orthopedic surgeon, the first thing that I notice when I look at this chest x-ray is the stark absence of the clavicles bilaterally. On the AP pelvis x-ray on the right, you can see a lack of symphysis pubis in the midline, as well as congenital coxa vara, worse on the left side than it is on the right side. So they want to know what the most likely diagnosis is: cleidocranial dysplasia, renal osteodystrophy, spondyloepiphyseal dysplasia, hypothyroidism, or bilateral slip capital femoral epiphysis. Cleidocranial dysplasia, or dysostosis, has all the typical stigmata mentioned in the previous question: a widened cranium, micrognathia, clavicle dysplasia, complete or partial absence, a narrow pelvis without symphysis, and scoliosis. Failure of formation of the midline structures, and autosomal dominant penetration, and bilateral coxa vara are typical stigmata. Back to the question. An 8-year-old boy presents with extreme shoulder motion and frontal bossing. The shoulder motion extremes are due to the lack of the clavicles, and you guys had 98% correct at cleidocranial dysplasia, so excellent work on that question. Vertical talus. What is the preferred treatment for newly diagnosed irreducible congenital vertical talus in a toddler? Casting followed by open reduction and Achilles lengthening, serial Ponseti casting, percutaneous Achilles lengthening, talectomy with tendon interposition, or subtalar fusion with soft tissue release. First of all, you need to know that with vertical talus, it'll be presented with multiple different types or names, such as convex pes valgus, rocker bottom foot, or talipes equinovalgus. The clinical appearance is such as you see in the infant picture on the left-hand side. Often associated with syndromes, with spina bifida and chromosomal abnormalities leading the way. X-ray diagnoses are key and very testable material and very commonly asked. The X-ray you see on the right, you see the flat surface on the dorsal surface of the foot near the red arrow. This is because this is a plantar flexion lateral view X-ray. This is an attempt to see if the navicular will line up and reduce with the talus. If it does not and remains dorsally dislocated, then you have a vertical talus radiographically. Casting is used to stretch the tight soft tissues, but usually not able to completely reduce the talonavicular joint, and a surgical release is usually necessary at or about 6 to 9 months of age. So back to the question. What they're really asking is, what do you need to do to treat congenital vertical talus, and specifically, what different things do you need to do than you would do with a typical idiopathic clubfoot? With an idiopathic clubfoot, the answer would be 2, serial Ponseti casting. However, with vertical talus, because we're not typically able to completely reduce the talonavicular joint, casting followed by open reduction and Achilles tendon lengthening is the appropriate answer. And I'm thrilled to see that 87% of you got the correct answer, which is number 1. Diastrophic dysplasia. What is the genetic cause of the dwarfism characterized by a hitchhiker's thumb, cauliflower swelling of the ears, and severe club feet? FGFR2, FGFR3, sulfate transport protein, CBFA1, or GS alpha protein. What this is basically making you do in this question is recognize what diastrophic dysplasia is. The term diastrophic implies twisted or distorted form of dwarfism. It's an autosomal recessive phenomenon and is characterized by a mutation on the sulfate transporter protein with undersulfation of the proteoglycans throughout the body. The typical stigmata mentioned in this question, cauliflower ear, hitchhiker's thumb, cervical spina bifida, and cervical kyphosis, are several of the very significant musculoskeletal issues associated with this disorder. They have a very short stature, and again, the twisted dwarf with severe club feet, hitchhiker thumbs, and significant spinal deformities as well. Back to the question. What they're asking you here is it's a known genetic cause, and they want you to know what is the mutation and what is the mutation's product. In this instance, that is number 3, a sulfate transport protein. And 84% of you got this correct, which is fantastic. Marfan syndrome. Marfan syndrome is an autosomal dominant disorder which results from a defective gene encoding for what? Again, a gene byproduct question. Number 1, elastin. Number 2, fibrillin. Number 3, fibroblast growth factor. Number 4, collagen type 1. And number 5, collagen type 2. The answers to the questions that you need to know for Marfan syndrome involve this chromosome 15. Occasionally they'll throw that curveball in there to make sure you understand that's the location. But fibrillin is the product of that chromosome and that location. They have an arm span greater than the height, lens dislocations, mitral valve prolapse, and significant ligamentous hyperlaxity. The musculoskeletal ailments include scoliosis and significant arachnodactyly. So back to the question, this is just an answer that you have to know these products in order to understand and answer this question correctly. Very excited to see that 93% of you got the correct answer, which is number 2, fibrillin. Tarsal coalition and perineal spastic flatfoot. A 13-year-old girl presents to the office for the first time with a history of recurrent ankle sprains while playing soccer. Clinical examination demonstrates pes planus. A radiograph shown in figure A. What is the most appropriate next step in treatment? Let's look at the x-ray below and see what we have first. We can see that we have an abnormal connection between between the navicular and the calcaneus, as seen in the direct center of this radiograph. Classic radiograph for a calcaneo-navicular coalition. The question, however, wants you to answer the question, what is the most appropriate treatment from the get-go? First of all, calcaneo-navicular coalitions are the most common cause of spastic flat feet, or pes planus. Commonly, they present as recurrent ankle sprains, as seen in this question, and other causes may include trauma or inflammatory disorders, such as JRA. A calcaneo-navicular bar may be seen on the oblique view, as we saw in the radiographs in this question. The initial treatment is always going to be casting or some form of conservative measure. If you go down the route of surgical management or failed conservative management, a CT scan is advisable, as there can be secondary or additional coalitions in the hindfoot. The talocalcaneal coalition requires CT to measure the percentage of the joint involved, and when 50% or less of the joint is involved, resection is an okay alternative. More extensive involvement requires more aggressive procedures, such as an arthrodesis. So back to the question. It's a 13-year-old girl who specifically, say, presents with recurrent ankle sprains while playing soccer. The most appropriate next step in treatment in this answer is 5, cast immobilization, because they don't give you any delineation of any other conservative treatment attempted thus far. 59% of you got this answer correct. 38% of you picked option 2, which is coalition excision. I think that answer would be correct had they in the question mentioned that they tried casting previously and failed in that conservative measure. But since they did not, conservatism will be the appropriate answer, and it's cast immobilization. Montasia fractures. A 4-year-old girl sustains a buccal fracture of the ulna and an associated radial head dislocation. Closed reduction and immobilization of the arm in 110 degrees of flexion, as swelling allows, and full supination enhances the stability of the injury by which of the following: tightening of the interosseous membrane, tightening of the biceps, eliminating plastic deformation, relaxing the pronator quadratus, or protecting the posterior interosseous nerve. With Montasia fractures in children, it's key to make sure that the x-rays they give you have the elbow and the wrist in the film, or that they explain it to you as they did in this particular question. That is incredibly important, as you need to make sure that the radial head reduces. Casting these in hyperflexion and supination relaxes the biceps and tightens the interosseous membrane, thereby enhancing your chances of maintaining a reduction. So back to the question, 78% of you got this correct, that hyperflexion and full supination enhances stability by tightening the interosseous membrane. The key part of this question that makes it correct is that as swelling allows. A lot of these children will be very swollen, and you may not be able to hyperflex due to safety reasons for compartment issues. SCFEs, slip capital femoral epiphysis. A 13-year-old obese boy complains of a 3-month history of left knee, thigh, and groin pain. His pain has significantly worsened over the past week. He denies pain in the right leg. Radiographs are taken and shown in figures A and B. The history and physical do not reveal any findings concerning for an endocrine disorder. What is the preferred method of treatment? Well, let's look at the x-rays that we have below. On the left-hand side, we have an AP pelvis, and on the right-hand side, a frog lateral x-ray of the left hip in particular, which is where he's symptomatic. You can see rarefaction or widening of the physis in this proximal femur. And on the frog lateral, you can see a slight slippage of the epiphysis in that regard. So the questions that the answers they have for this question are subtroch osteotomy, non-weight bearing for the left side for 6 weeks, bilateral in situ fixation, in situ single screw fixation across the left physis only, or varus derotational osteotomy of the proximal femur. Well, first let's go through some key pieces of information to know about slip capital femoral epiphysis. It most commonly occurs in overweight males during their rapid growth spurt. By far, the #1 treatment on any question asked will be pin in situ or where reduced by positioning without force. Endocrine workups are necessary if the child is less than 10 years of age or has other stigmata associated with endocrinologies. Pinning bilateral is definitely indicated if there are endocrinopathies, and this is something that they will have to allude to in the question in order for this to be correct. Back to the question, the preferred response, accordingly, is in situ single screw insertion across the left proximal femoral physis only. 94% of you got this answer correct, which is absolutely fantastic. An 11-year-old obese male presents with a slip capital femoral epiphysis. Which of the following figures accurately represents the methods used to determine the radiographic severity of the epiphyseal slip and help to guide treatment? You can see on the left-hand side, the farthest to the left, is an epiphyseal diaphyseal angle. The second from the left is Klein's line drawn on the superior aspect of the femoral neck. The acetabular index is the central photograph. Shenton's line is the line drawn from the femoral neck through the obturator foramen. And the center edge angle is the furthest to the right. So slip capital femoral epiphysis has a scenario where the femoral neck is displaced anteriorly and externally. The Southwick severity angle is what was depicted in this question and is the answer. The epiphyseal shaft angle is the key, with the difference being mild of less than 30 degrees, moderate 30 to 50 degrees, and severe greater than 50 degrees. An 11-year-old boy presents with the above-mentioned scenario. The preferred answer is 1, and I'm delighted to see that 81% of you got this answer correct. Developmental dysplasia of the hip. Which of the following concepts regarding pediatric hips is true? The proximal femoral physis and greater trochanteric apophysis develop from different cartilaginous physes. The proximal femoral physis grows at a rate of 9 millimeters per year. Normal infant femoral anteversion is between 10 and 20 degrees. The ossific nucleus of the proximal femur is visible on radiographs by 6 months of age in most children. And slip capital femoral epiphysis typically occurs through the zone of proliferation. So again, they want to know which one of these is true. So let's go through some typical information that's needed to answer questions on developmental dysplasia of the hip. First of all, on the slide you can see below with the x-ray, the red line that's just horizontal is Hilgenreiner's line. And the blue line, which is vertical, is Perkins' line. That divides the hip into 4 quadrants, as you can see in the radiograph below. The proximal femoral ossific nucleus appears at 6 months of age. If you can draw these lines on the x-ray, which they'll have to show you on the question, you can make the diagnosis without the presence of an ossific nucleus, which is why they're asking you this question. So back to the question. The correct answer is 4. The ossific nucleus of the proximal femur is visible on radiographs. And 70% of you got this answer correct, which is answer 4. Looks like about 1/4 of you picked the answer 1. The proximal femoral physis and greater trochanteric apophysis develop from different cartilaginous physes. Actually, in the proximal femur, those 2 physes are congruous with each other and don't separate until later in development. Neurofibromatosis. All of the following are associated with neurofibromatosis except. So be leery of questions that say except or which is correct to make sure that you read it thoroughly. Smooth bordered cafe au lait spots, posterior medial bowing of the tibia, short sharp dystrophic scoliosis, cutaneous neuromas, and autosomal dominant transmission from mutated neurofibromin gene. So with neurofibromatosis, the NF1 gene is located on chromosome 21 and has been labeled neurofibromin. Typically, they present with cafe au lait spots that are smooth, have smooth borders, hemihypertrophy, as you see on the right, significant sharply angulated scoliosis, and anterolateral bowing of the tibia, compared to the posterior medial bowing that we talked about earlier in this section. Plexiform neurofibromas are a hallmark and pathognomonic for neurofibromatosis. So back to the question. All of the following are associated with neurofibromatosis except 88% of you got this correct, except posterior medial bowing of the tibia, and that's correct because anterolateral bowing is what's associated with neurofibromatosis. The rest of those are correct. Achondroplasia. Dwarfism caused by a defect in fibroblast growth factor 3, FGFR3, is associated with all of the following traits except, again, an except question, rhizomelic limb shortening, normal intelligence, frontal bossing, cervical spine instability, and spinal stenosis. Achondroplasia is the most common skeletal dysplasia. It's autosomal dominant in presentation, and FGFR3 mutation is the hallmark. The typical physical stigmata seen are frontal bossing, foramen magnum stenosis, rhizomelic limb shortening, and thoracolumbar kyphosis, as well as lumbar stenosis. They typically have a champagne pelvis, as you can see in the lower left, and significant shortening of the pedicles, which is what leads to the stenosis. So back to the question, which of the following are not associated with FGFR3 or achondroplasia? The correct answer here is 4, cervical spine instability. All of the others are typical stigmata of achondroplasia, and 84% of you got this correct, which is excellent. Osteogenesis imperfecta. Which of the following pediatric congenital disorders is caused by a glycine substitution in a procollagen molecule? Scurvy, osteogenesis imperfecta, fibrous dysplasia, dystrophic dysplasia, or ochronosis? OI, or osteogenesis imperfecta, is an inability to make normal type 1 collagen at normal rates. Typical stigmata is a glycine substitution on the procollagen molecule, which then leads to abnormal cross-linking and hence the inability to make normal type 1 collagen. So this question is just a tidbit of information that you have to know about osteogenesis imperfecta in order to get correct. And incredibly, 77% of you got this right, which is fantastic. Issues, so I can understand that confusion. Charcot-Marie tooth. A 22-year-old woman is concerned about frequent ankle sprains and an awkward gait. Lower extremity nerve conduction velocities show prolonged distal latencies in the perineal nerves. DNA testing shows a duplication of chromosome 17. Which of the following images is most likely the radiograph of this patient? Well, the image on the left shows an accessory navicular. The image in the upper image in the middle shows a calcaneonavicular coalition. The lower image in the middle shows what appears to be a cavus foot. The upper image on the right is a normal x-ray. And the lower image on the right shows a ball and socket angle, typical of multiple hindfoot coalitions. Charcot-Marie tooth disease is an autosomal dominant disorder that causes cavus feet, hammer toes, and mainly motor deficits. The most affected muscles are the anterior tibialis, peroneus brevis, and the intrinsic muscles of the foot and the hand. Back to the question. Which of these images shows that typical x-ray consistent with Charcot-Marie tooth disease? And it is the preferred response is image C, which is 73% of you got this correct, which is excellent. Myelodysplasia, or spina bifida. A 4-year-old girl with an L2 myelomeningocele presents for routine follow-up. Pelvic radiographs reveal a complete dislocation of the hip with well-formed acetabulum and a normal right hip. Her gait is symmetric with use of a walker and a brace. Which of the following treatment options should be offered to the patient at this time? Right-sided femoral shortening osteotomy, continued observation and routine follow-up, left greater trochanter advancement, left-sided pelvic osteotomy, or open reduction of the left hip. Hip dislocations are a beloved question in myelodysplasia. The photograph at the bottom of the slide depicts why L3 and L4 are the most common levels to have hip dislocations. Simply, you have unopposed flexion and abduction of the hip in these individuals. Surgical treatment is very controversial. L3 and higher levels almost always are treated with observation, even in the most aggressive centers. Back to the question. 66% of you picked option 2, which is continued observation and follow-up. And the reason that's correct is this question says that this is an L2 level myelomeningocele. So L3 levels and higher have very poor results with attempts at reconstructive maneuvers. And the other third of you that didn't pick answer 2 picked 5, which probably would be correct if this was an L4 or L5 level spina bifida. Osteopetrosis. An enzymatic mutation leading to abnormal carbonic anhydrase function in osteoclasts would lead to the condition best illustrated by which of the following x-rays in figures A through E. In figure A, you can see a loss of normal definition in the metaphyseal region of the femurs. Figure B looks most like Paget's in the left hemipelvis and right proximal femur. Figure C, typical stigmata seen with melariostosis and candle wax type material. And figure E, a bone infarct. Figure D has the appearance of a malignancy with ill-defined borders on the x-ray. Osteopetrosis is an autosomal recessive disorder that maps to chromosome 11. It's a failure of osteoclasts to remodel and is specifically due to a carbonic anhydrase dysfunction. There's a very high mortality rate, and the treatment is largely with bone marrow transplant. The x-rays you see below are typical, with lack of osteoclastic remodeling of the metaphyses, a rugged jersey spine as seen on the right. So as you can see on the right, with a rugged jersey spine, the correct answer on this one is going to be figure A, which is number 1. About half of you picked figure B. So the correct answer on this is figure A, as it is osteoclast remodeling disorder leading to osteopetrosis.